Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Catherine, would you like to introduce yourself?
Yes. Hello, everyone. My name is Catherine. I'm the intern at Blum Center.
Thank you. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Catherine, who will introduce you all today's guest speakers.
Joining us today, we have the nurse practitioners Samantha Calabrese and Raina Basak from the Department of Gastroenterology. They join us today to give a talk on understanding and managing our digestive health as we age. Please join me in welcoming Samantha and Raina.
Hi, everyone. I'm Raina.
Hi, I'm Samantha. Nice to be with you all today.
Yes, and we're part of the Neurointestinal GI Motility Division and Outpatient GI here at MGH. Should we start sharing our screen? Okay. Oh, 1 second. Sorry. Apologize. Okay, here we go. So what we're going to talk about today is our digestive health, and as we grow older, right? Some of our objectives is just to discuss gastrointestinal health as we grow older, describing aging and how it particularly pertains to our digestive health, but in particular today, we're going to focus on our bowels. I think we'd be here till Christmas if we were going to discuss the whole GI tract. We're going to define constipation. We're going to pay a lot of attention to constipation as this is one of the most common disorders, not in for general public and for our GI symptoms, but also as we age. Risk factors, prevalence, why is it so important to evaluate, treat, and discuss? And understand other changes in bowel motility, difference between genders, and other age-related alterations that occur. Okay, so our whole GI system, just a quick overview, is so complex, right? We know it starts from the mouth to the anus. It's not just our stomach or our bowels. So it's a muscular tube extending from the mouth to the anus and concludes our esophagus, right? Our tube that helps carry our food down to our stomach. Our stomach, small intestines, our large intestines. Then we have some of our digestive organs there, liver, gallbladder, pancreas. And then a whole network of sphincters and hormones, our enteric nervous system, right? Lymphatic system and circulatory system all work together to make sure that we are able to digest, absorb, excrete, and provide immune defense. So what's aging? Aging is a series of changes that occur over time, especially during our post-mature mature life, that triggers an increase in vulnerability to change, right? It makes it harder for our bodies to adapt to things a little bit. And these mechanisms, as we age, may lead to some neural injury and functional changes in our digestive tract, especially with some loss of plasticity, neuroplasticity, and compliance. some structural changes, which I'll further discuss, and especially for our bowels, we could see more diverticulosis. And aging just in general affects our motor and sensory physiology. This is just a quick overview of a chart. Like I said, we are going to specifically talk about our bowels today, but just an overview of what can happen through our whole GI tract as we age, right? We're more prone to some swallowing issues, just going from top to bottom as it's harder. We have decreased saliva, so there's dry mouth, sometimes makes it harder for us to even chew and initiate a swallow. Esophageal changes, right? We can start having weakness in some of the esophageal sphincters, and even just how our muscles contract in the esophagus. The stomach can see some decreased motility, making it harder for actually, in particular, liquids to empty, as well as the stomach can have some reduced gastric tone, which is why sometimes in the elderly, you see patients feel full quicker, right? Or they don't have as much of an appetite. Then the small intestines and colons, we just see some decrease, can have some decreased motility and some contractions. So what's happening in particularly that's changing, right, as we grow older? And we don't know a lot about our enteric nervous system, but what we do know, right, and the enteric nervous system, let me just quickly start, it's what we call kind of, you might have heard of it as our second brain, right? It's a really complex network of neurons that's located in our gut, and it really governs a lot of how our GI system functions. And it operates separately from our central nervous system, but they heavily communicate together. And it's in charge of a lot of our intestinal motility, vasodilation, absorption, and secretion. And so as we age, like I said, as it's noted in the slide, we don't know a lot, but from what our studies have suggested is there is some neurodegeneration. There can be changes in our smooth muscle where they're not as strong as they used to be, or not contracting as effectively. And when this happens, right, there can be an increased prevalence because when they're not able to contract as well, that calls for some harder type stools. And we think of more, and I'm going to discuss this more later, but of what we call our slower transit, right? And it's making harder for us to pass. So that's why constipation, one of the factors of why constipation can be so prevalent. The loss of cholinergic neurons and some even inhibitory neurons, resulting in uncoordinated contraction and discomfort. As we age, especially in our 7th decade, right, and 70s and higher, we see that these neurodegenerative changes are really seen predominantly with swallowing, our bowels, and continence, whether it's bowel or bladder. There was a study actually that was published back in 2019 in the British Medical Journal where they actually was looking at where in the colon was there some decrease, right? And they actually showed that the decrease was in more of the ascending colon besides the descending, which I thought was very interesting because we have so many of these studies of what we don't know, and this study in particular showed where in the colon actually is there changes. And that study particularly showed that increasing explained there's also a decline in cholinergic function. This next slide is a chart of some of the anatomically what's happening. We can see some decreased strength in some of our anal sphincters, right? There's some slowed transit time. Our sensations can slightly get decreased, our compliance and capacity. So these all play into part of what's changing. So, like I said, we're going to really focus on constipation as this is so common. And what is constipation, right? And this is let's define it according to the Rome 4 criteria. And so it pretty much, you have constipation if you meet two of the more of these following criteria, okay, which is straining more than 1/4 of the time or 25% of the time you move your bowels, lumpy or hard stools. Let's look at what that means. Right here to our right, we have our Bristol stools chart. And the lumpy and hard stools are particularly, as you can see, in type 1 and type 2. Those really hard pebble-like stools, or type 2 is like that sausage shape, but still pretty lumpy and hard. If those are 25% of your stools, then sensations of feeling incomplete, where you pass your bowels, but you still don't feel empty, like there's still so much more in you. Sensations of obstruction or blockage, making it really like straining and making it really hard to actually pass. Using manual maneuvers, whether it's like pressing on your stomach or pelvic region, or using your fingers actually to help get stool out. Fewer than 3 spontaneous bowel movements per week is consistent with constipation. And sometimes even loose stools, right? A lot of times you hear patients, I had diarrhea, I'm not constipated. But actually sometimes loose stools without even using laxatives can be a sign of constipation, where it's actually what we call like overflow diarrhea, where it's surpassing, there's still a lot of stool in the colon. So having any 2 of these symptoms for more than 3 months, you meet constipation diagnosis. And let's see how common it is. So in the United States, about 12 to 19% of people have constipation. And out of those, 24 to 50% of older adults suffer from constipation. So we know this is very, very common. And this increases its age, especially after the age of 65. 26% in males and 34% in females. And why is that? Why is it so much more prevalent in females? Has to do particularly factors of pelvic floor dysfunction, particularly, we have to think about like obstructive history, pregnancy histories, hormonal changes, right? Progesterone can slow things down, medications, and just difference in physical activity. 10 to 18% of adults in the community are using laxatives, as 74% of nursing home residents are having to use laxatives.
All right, and so I'm going to actually take it over and talk a little bit more about the constipation. So we have constipation. We got a great overview from Raina about the description of constipation, but when I have a patient in front of me, I actually will break down constipation into these kind of like subcategories, because it's important to understand that constipation isn't just hard stool. It isn't just things not moving from one place to another. It can also be all of these things combined. So we kind of think about chronic constipation, where, yeah, things are not necessarily, there's no evidence of slow transit constipation, which is something discussed below, or dysenergic defecation. They're not meeting criteria for those specific diagnoses of constipation. So we kind of just call that chronic idiopathic constipation. They don't have significant pain to make us think it's IBS with constipation. So that is kind of like a broader subtype of constipation. Then we have slow transit constipation, and that is really what I describe to patients as things really don't move well from point A to point B. And that can kind of go back to what Raina was saying in terms of the smooth muscle, the contractions are maybe not working as well as they once were. Again, this can be seen in all age ranges, but bringing it back to our aging population, that may be, something that we're seeing. And we assess this with a SITS marker test, which for the patient is a plain film x-ray, but as you see on the right-hand side, there's these little rings in the x-ray, and those are actually SITS markers. So those markers help us say, okay, these markers are actually remaining, they weren't moving through the colon. If there's many markers remaining, that actually tells us things really don't move in the pace that they should be moving, and that's how you make that diagnosis. Then we have dysenergic defecation. Again, Raina was perfectly describing this. Really, the inability of the muscles to coordinate to help us expel stool. Things may get all the way to the bottom, and we're really having trouble pushing it out. you think about it like a door is partially open and you're trying to get something or someone out that door, it's not going to work unless the door completely opens. Again, and those muscles can change as we age, can change with, just like Raina was saying, childbearing, history of vaginal births, even C-sections, because that area strains those muscles, and the muscles may either become actually really tight and difficult to pass through, or so loose where the muscles can't coordinate to pass that more formed stool. And then we have our irritable bowel syndrome, or IBS, with constipation, where there's really pain, discomfort associated with harder, more difficult to pass stool. Now, we also see a lot of secondary causes, particularly with our aging population, more of which I'll kind of discuss on the next slide, but this actually becomes probably more prevalent as we age, these secondary signs. And so this is actually something that I came across when we were doing research for this presentation, but something I probably will start implementing, particularly with my aging population, because I think sometimes we get so focused on subtyping patients and not really taking a step back and saying, okay, well, what are the risk factors? And so this really put it together, the 10 Ds of constipation in elderly. So drugs, medications. I think sometimes, we're all trying to help solve a problem. And of course, our first step is like medications that we know that can be helpful for patients. But, are we actually contributing to or exacerbating potentially an underlying constipation already? Most medications people are taking, they're taking them for a reason. So oftentimes we do augment the medication regimen by potentially adding in something to help soften the stool. But really, we should take a step back and think, okay, did constipation come about? When did this change? Why did it change? Did we change medications? And so we do, take a good survey of the medications initially to say, okay, maybe we actually know where this is coming from. Similarly, defecatory dysfunction. I know we just talked a lot about this, but this does change as we age. Like I said, the muscles may lose the elasticity. They may not be able to coordinate around that stool, and there's great interventions for this if we're able to actually capture this as the problem, which sometimes takes a bit of time to get to. There are tests that specifically look at how the bowel coordinates, how the bowel feels, and, can it actually feel the stool that's there, or is there not a lot of sensitivity in that area and there can't? So that, I think, is an important factor that maybe takes a little bit of time to get to, but once we get to it, we actually can help with pelvic floor physical therapy, like physical therapy very much focused on that pelvic area. And I think, of course, again, as we age, there are other comorbidities that come about. There are some diseases that carry this risk of constipation a little bit more, a lot of neurological conditions, multiple sclerosis, ALS, history of cerebral vascular accident, stroke, renal disease, Parkinson's. I know right now there's just a lot of research out there about Parkinson's and bowels and constipation, and what actually comes first. Do patients notice constipation and then get neurological symptoms? But a lot of GI symptoms are very intertwined with other comorbid conditions. And so taking a step back and trying to recognize, okay, maybe this particular patient is at more risk for this. Decreased caloric intake. I think that's, again, a big one. As we age, some of the conditions that we didn't focus on initially, but like probably really like lack of taste, our taste buds change as we age, decreased hunger, decreased ability to take in as much food as we once were. But in turn, does that decrease our hydration? Does that put us at risk for harder stool? I think all those things are very important to get a full picture of our patient and not just focus on what's going on in your intestines. Similarly, thinking about dementia, there may be forgetting of meals. There may be just lack of appetite. There may be a lot of contributing factors with that. That can be, of course, to decreased fluid intake, potentially medication burden, those types of things that put that as a risk factor. Decreased physical activity, again, I'm not saying we have to run marathons, but even that little walk that you do around the neighborhood, that promotes motility. That's important. And so as we age, likely because, again, of other comorbidities, increased pain, joint aches or pains, arthritis, our activity decreases, and we might not realize it until we're thinking, oh, have I become more constipated actually? And that may circle right back to the decrease in physical activity. The derangements in electrolytes, again, kind of goes back to that hydration. We're not drinking as much, we're not balancing our diet as well. Without hydration, our electrolytes do deplete. Those depletions can put us at risk for constipation. So making sure you are hitting your food groups, calcium, potassium, magnesium, those kind of things, they're very important for gut health. Decreased privacy. And I think, when I think about this more, it probably relates to that statistic, thinking back to roughly like 70% of patients in nursing homes take laxatives. Think about it. If you don't have the privacy of your own home, it's harder to have a bowel movement sometimes for patients when they're out in public. I even see this a lot. I know we're talking about the aging population, but I'll see this in patients of all age ranges, thinking back to, when they were in elementary school, it was embarrassing for them to ask to go to the bathroom. So if you're not listening to your urges when you have to use the bathroom, that in turn can actually increase your risk of not going as regularly. So that's, I think, where the decreased privacy comes in too, because you're, maybe you do have an urge to go, but you're out, dining with friends or not in your own home, and you kind of ignore that urge and don't go. That puts that risk factor in place. Dehydration, we've talked about it probably with every single one of these. It goes in hand. And depression, that is, again, can go with lack of appetite, not really wanting to get up and do things and be active. And, we think about that as a risk factor, and even in the aging population. And so, we can't do a presentation like this without talking about red flags. No, we aren't your providers, but we also want you to know when to contact your providers. So constipation is normal. We can talk about constipation all day in a normal setting, but there are certain risk factors that we do want to make sure we're talking about with your providers. So any blood in your stool, there's varying degrees of this. There's varying things that can cause this, but if this is new, if this is something you've never talked to your provider about, talk to them about it. Anemia, again, your blood counts are going down. People are scratching their head. Why? You have GI symptoms with this, talk to your provider. Weight loss, intentional, you're working at it, you're exercising, good. If it seems to be falling in a way that doesn't seem to be in proportion to what you're doing, or weight loss that's not intentional, meaning you haven't changed any of your habits and yet the weight's coming off, talk to your provider. New and unexplained constipation, again, this can happen, right? Our bowels change. We just told you all the potential aging changes that could happen to trend somebody towards constipation, but it just seems to kind of hit all of a sudden, makes you scratch your head a little bit, particularly as we age. Is there something structural, inflammatory? Is something going on that would cause that? Obstructive symptoms like new or different pain, fever, chills. Is there an infectious process going on? Just want to be on high alert of that. And then, of course, your family history is very important. Genetics plays a role in some things, particularly colon cancer, inflammatory bowel disease, things we're focusing on bowel-wise. So just be mindful of these when you're talking with your providers. So, I did want to talk a little bit about potential complications that are associated with constipation. And this can be, for sure, yes, in the aging population and in general. But, these things are aggravating for patients, but they also can, think back and directly relate to constipation. So hemorrhoids, anal fissures, those are two things that can occur for patients rectally that can cause a lot of pain, a lot of discomfort. Bleeding can be exacerbated when you're straining. Also think about it, the tissues change over time. As we age, likely more prone to these particular things. So those are a couple things I wanted to mention. Incontinence, impaction, Raina did a great job explaining fecal incontinence, but that can actually happen. You can leak stool even if you're constipated. And again, that can increase and be a big barrier for patients as they age, particularly, it disrupts wanting to go out, wanting to socialize, wanting to be out with their friends at any age, but the increased risk as we age makes this more prominent problem that I also think is underdiagnosed in some ways, because it's a hard thing to talk about. You know, we sit here all day and talk about these things, so we can talk about them very easily, even at a dinner table. For patients, that's not as easy. So don't feel bad about bringing that up to your provider. Rectal prolapse, so that is when the tissue of your rectum actually prolapses or falls down. And you may see that when you're straining to have a bowel movement, or just even having a bowel movement. You may go to wipe and you may feel something, oh, something feels different here. And that actually does and can increase again as we age, because that tissue is more lax. It's not as tight. The muscles aren't able to hold all that in. And so again, continued straining, constipation, all of those things can contribute to that, but you're at an increased risk again with age. Diverticulitis, you know, again, something that increases with age. And I actually think there'll be a whole talk about this. I think one of our colleagues is doing a whole talk about this at the end of the month. You know, not directly everybody who's constipated will have diverticulitis, but there's little outpoachings of our colon that are created. Constipation can exacerbate these. Age in general, the tissue's changing, that can be exacerbated. Diverticulitis is an infection of those outpoaching. Something gets in there, it's inflamed, that, you know, comes with pain, fevers, etc. Urinary issues, right? There's only so much space in that area, so it's very real to feel like there's both urinary issues and bowel issues, laxity of the pelvic floor. I know we keep going back to that, but very prominent as we age. Again, bowel obstruction, those things, you know, not necessarily things that I see every single day, but can be a risk factor over time as the bowels, you know, lose their ability to do that contraction that they're able to do to help propel things out. I think, honestly, one of the more important things, of course, all of these are concerning medical complications, right? But the impact on quality of life is probably one of the #1 complaints that I have in all spectrum of all patients. But it really is a burden. You know, like I said, it impacts your social life. It impacts wanting to do things. You're feeling uncomfortable. But even more so, I think the economic burden was astounding, because think about, though I say patients don't like to talk about this, they don't, but there's a lot of medical costs that can be associated with this, whether that's medications, patients presenting to their outpatient provider with these symptoms. So it really is a burden for our patients, but also a burden that we hope can be alleviated economically as well in the system. So, of course, you know, we're not here to tell you what to do from a treatment perspective, but to actually really just tell you there are treatment options for this. And, you know, of course, in the aging population, we just said medications can contribute to the problem. So here, let's throw you more medications. But there are medications that are available and generally can be really well tolerated in all ages. And these are just kind of some of the over-the-counter regimens that I think about when I'm thinking about how to help my patients with constipation, how to soften stool, how to bring more water into the colon, how to even help some of that stimulation of the bowels. And then, you know, even on the lower end of this, the enemas, the suppositories, how to help those muscles when they can't coordinate well. How do we help activate them to help have a bowel movement? And then the next slide is actually just prescription medications, right? So this is all to say, hey, there are medication options out there if we are struggling with constipation. And there have been some studies. You know, I think a lot of times too, the elderly crowd gets kind of like left out of studies because risk benefit, you know, they're not the perfect research person because there's a lot of other complications that go on. But there is some data to suggest these are relatively safe. They're very bowel specific. So there's not a lot of systemic side effects, means there's not a lot of interactions. So all potential options moving forward. And I'm not going to spend a lot of time on this slide because surgery is something we really often try to avoid, but a lot of the research out there, particularly even for elderly patients, suggests that we really rarely want to do this. It's rarely indicated. Now, are there certain times where this is going to be the best in terms of offering a better quality of life, sustainability moving forward? Absolutely. But there's very specific criteria that need to be met, lots of discussions, lots of collaboration with multiple teams to see if that would be the best option for you. I think I wanted to spend, as we wrap up, a good amount of time on this slide, because I think though this is called a non-pharmacological treatment slide, it's really a prevention slide, right? Because we talked about, okay, there are changes that happen, particularly with neurons, particularly with muscles, but you're probably sitting there thinking, well, I don't have control over that. Like, what do I do as the patient? I think we talked a lot about hydration, exercise, keeping moving as much as you can, all the lifestyle modifications that every provider probably tells you to do just for your general health and well-being. But I think really taking a step back, making sure as the providers, we're reviewing medications, reviewing medical history. Are we exacerbating an underlying problem? Is this medication best for this patient? Is this prescription best for this patient? Trying to get in as much dietary fiber as you can. There is this saying, too much of a good thing is not always a good thing, but dietary fiber can really help nourish the colon. Definitely a lot of studies looking at that, both from a supplemental fiber perspective and dietary fiber perspective. It can help. Too much bulk, like I said, is not always a good thing. So in patients where things are already moving slow, might want like I said, does not have to be these strenuous exercises, just general walks around the block, keep things up and moving. Listen to your body's urges. And I think this one, I forget to talk about sometimes as a provider, but there are subtle urges that our body gives us to say, okay, now's the time that I think I feel like I have to have a bowel movement, and we're in the middle of something. We're all guilty of it. We're reading a book. We want to just finish this chapter. We're watching a TV show. But really the body is going to respond best when the urge is met as soon as we can. And kind of with that toilet training, right? Like thinking about, no, I don't want you to sit there and try to have a bowel movement all day long, but thinking about, is there a time that I generally feel the urge to have a bowel movement, and should I make it a habit to actually go sit there and try to have a bowel movement? Diaphragmatic breathing, that's really a breathing exercise that we work with a lot of our patients to really settle down the diaphragm, expand and contract and release in an appropriate way, because when that becomes all off, it's hard for our digestive tract to do the things that it needs to do. Kind of with that, avoiding straining. Like I said, I don't want you sitting there for hours trying to have a bowel movement. It's hard sometimes. Yeah, we're in a rush. We feel like we have to go. We want to get it out. We strain, and that just leads to more complications, things that I talked about before, hemorrhoids, prolapse, those types of things. We're putting too much strain on the body. Physically, something's going to happen if that persists. Proper body mechanics. Again, I think this is one of the easier interventions that sometimes is overlooked, but they're saying ideal toilet time 3 to 5 minutes. It's not supposed to be this 20-30 minute thing. Making sure your legs are positioned actually a little bit higher than your waist level is typically what's recommended. And this is a lot of stuff that pelvic floor physical therapy goes over if you do ever engage in that. But this is important, just remembering, like, it's not a race to do this. You don't want to force it, but utilizing these interventions will actually help decrease these risks over time. Diet, hydration, and there are other non-medication interventions that we talk about specifically in our GI practices, like cognitive behavioral therapy. There's a lot of thoughts and worries around bowels for everybody, especially if it's a problem, but especially as we age, because it impedes your quality of life a lot. And so trying to work with those worries, talking through these worst case scenarios, talking through interventions to kind of help as if the body starts to feel a certain way. These are really great interventions for patients that have been made into apps on your phone or your tablet or your computer. It's actually really accessible now, where before it used to just be one-on-one with a provider. There was hardly any access. Now we've kind of expanded that access to, you know, give you these things at home. It's been good. I think we want to wrap up and give everyone a chance to ask questions if there are any, but, you know, takeaway points. Aging can affect our gut. Like I just talked about, that doesn't mean we can't do anything from a prevention perspective, but remember, you know, there may be changes. The muscles may not be able to work as well as they used to. Your bowels may not be as complete as they used to be, or the opposite may happen. The muscles may be weaker over time and may increase your risk for accidents. So managing all of those things to the best of our ability, you know, kind of hitting the definition of constipation. In general, moving your bowels less frequently throughout the week, hard or difficult to pass stools. But there's often more to it than just that, right? Focusing as we age on those secondary causes, looking at the med list, looking at the comorbidities, you know, making sure we are actually taking a step back and not just throwing that diagnosis of constipation on there, but thinking, what are these other factors here to that? You know, we highlighted the alarm signs, talk to your provider about those things. You know, there are things that our elderly patients deal with in higher prevalence than other populations of patients. But, you know, thinking about this, tailoring it to our patients, making it a more specific patient discussion as opposed to these general recommendations are helpful for patients and providers moving forward. Thank you all.
Yeah.
And we're here to answer questions if we can.
Thank you, Samantha and Raina. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding the breathing technique. When should one do a breathing technique? When they are in the toilet, for instance, or on the toilet?
Yeah, it definitely can. A lot of times people will do this like after a meal, but there are techniques, breathing techniques, particularly associated with bowel movements. Some physical therapists will kind of say, like, think about it as you're like taking a deep breath and then like blowing out a candle, kind of like pursing your lips a little bit, like really focused on thinking about like blowing out a candle. Sometimes that helps, just like taking a deep breath in, and then the relaxation helps throughout the entire digestive tract and expelling a bowel movement.
Is this something that they can practice on their own at home, or should this be done with a physical therapist to ensure that it's done properly?
Good question. Yeah, usually we say even a physical therapist, it could be even a one-time visit, you know, talking through toilet positioning, certain techniques that can be helpful. It doesn't, you know, sometimes it is this like 6 to 8 week course with a physical therapist, but sometimes it is just like, hey, I've been doing these techniques. Is this right? And they can really help with a lot of that.
Thank you. Our next question is regarding what are your thoughts on suppositories?
Well, I think that's a tricky question because I think it means what. I think there's a lot more evaluation to that question. It's more of what are your symptoms? What type of constipation, right? How often do you need to use them? Because a lot of the times, are you just unnecessarily inserting suppositories if there's other things that we could do to help you before that? And honestly, if there's a lot of suppository use, it makes me question, are we missing a pelvic floor dysfunction here? So a proper evaluation, I think a suppository is appropriate in certain settings.
Thank you. Our next question is regarding diet. Which foods are best when you're feeling constipated?
Well, that's
whole presentation.
Yeah.
Right?
Again, that's that's really hard to say. I don't know how to, I know we talk about fiber, but I think we mentioned a little bit too, is like, if things are actually moving very, very slow, right? Fiber's more bulking, and at times actually it could not be as helpful. Making sure it's just so important that it's a well-balanced, wholesome diet. We want to make sure we have still enough protein, hydration, and fiber, right, to help with this. There's really no magic particular food. If you're talking about some natural things to help you move your bowels, right? I know everyone's heard of prunes, right? Prune juice. Prune juice can be like a very nice natural laxative. Kiwis actually are known to help get things going.
I was going to say, yeah, there was like a relatively recent study that looked at 2 kiwis a day in aiding in constipation, and there was some positive results from that. But, you know, yeah, it's definitely variable and definitely patient dependent for sure.
Thank you. Our next question is regarding laxatives. Is it safe to be on laxatives long term?
Again, probably provider specific and patient specific. In general, there has not been data to suggest that Senna, Dulcolax laxative cause any long-term harm to the colon that we're aware of at this point.
Thank you. Earlier on, you covered a little bit about how we go through muscle changes as we age. Are there any exercises or lifestyle changes that we can do to help with the muscles and prevent or slow down muscle changes?
Yeah, I think it's a little bit of like everything. I think we hit it on the tips page, where just making sure that we're regularly exercising or just regular physical activity, right? That just helps with muscle, eating appropriately, making sure we're getting the appropriate amount of protein, the nutrition. We got to fuel our body, right, to make sure that everything's working to its best of its ability. And any kind of like abdominal, let's say, surgery or history, even, pregnancies, can make you more prone to pelvic floor dysfunction. Even, let's say, our job, if we're regularly sitting at our job for 8 hours on the computer, right? That in itself promotes like weaker pelvic floor muscles. And it's so common, just not in the elderly, but obviously it gets exacerbated as we get older, right? But it's so much more common than what people think. So I think regular movement, proper fueling your body. I know we talked about some of the better toilet positioning. It's so funny that how we all sit on a toilet when we know like that 35-degree angle when our knees are slightly higher than our hips, right, is such a better angle. Our puborectocalis muscle helps it in the regular way we sit on the toilet, right? It's kind of bending our rectum as opposed to that other angle we spoke about, which will help straighten and release it. So making these small changes can really help improve things.
Thank you. And we have another question regarding exercise. Are there any particular exercises that would be helpful when feeling constipated?
I think it's hard. I think it's actually like the actual practice of physical therapy over time, like acutely when constipated. I think kind of probably going back to just what you were talking about, the toilet positioning and breathing is probably going to be the most effective, but it's actually really retraining those muscles over time that will end up helping with that to ideally prevent constipation or exacerbation of constipation. But when you're acutely constipated, yeah, trying to keep those knees a little bit elevated, that helps relax the muscle to the best of its ability. That used to really be, thinking back, I feel like we learned this when we started here, like how people used to have bowel movements was like really squatting. And so like, of course, as technology and things have increased, we have toilets and things like that, but that was the position that actually like anatomically helps you have a bowel movement best.
Thank you. Our next question is regarding laxatives. Are you able to repeat the information on laxatives discussed, the names and their effects?
I can definitely go back to that slide. I really didn't talk about it a lot because I know, I'm not here to, let me see if I can go back. I'm not here to be like your treating provider, but these are like very general descriptions of all the medications that are available over the counter. So psyllium husk, Citracel, Fibercon, Benefiber, those are fibers. Colase is a stool softener, so it's really just going to maybe bring a little bit of water in, try to soften stool. Miralax, lactulose, even magnesium, drawing in water, helping things move through a little bit better. Stimulant laxatives, Stena, Docalax, those are more going to stimulate the bowel contractions as opposed to just bringing in water alone. Again, everyone's different, everyone's patient specific, it's different, comorbidities, all of those things play a role in this. Some things have more evidence than others, right? Like Colase, stool softeners, not a ton of evidence. You ask everyone, you go to the hospital, they're going to put you on a stool softener, but there's actually not so much evidence about that. So it is definitely a discussion with your provider, but this is just like a general overview of the different ways these medications work, the different types of medications available. Similarly, the next slide just talks about prescription medications. Again, everything's so patient specific and what works for which patients.
It's helpful when you do see your provider, like being really mindful of like knowing your symptoms, like are your stools, you could have I think people tend to believe that constipation's just hard stools and you're only moving your bowels once a week or things like that, but you could actually have soft bowel movements and still be very constipated. So knowing on average what your frequency is and consistency is, and some of even your symptoms. Are you feeling belly pain with your bowel movements? Are you feeling still bloated, or are you feeling like not empty, but you went a lot? Those really, knowing those things help the providers for better treat you with which type of intervention, right? If your stools are running softer, my go-to would not be to start you on Miralax first, right? And I think that's kind of like everyone's go, oh, just take some Miralax, but that's softening a thing. So being prepared of knowing what your symptoms are can really help guide which is the best intervention for you.
Thank you. And we do have a question under the row bulk forming laxative. What does minimal SE mean?
Oh, minimal side effects. So it's typically well tolerated for patients because a lot of these are so gut specific. There's not a ton of systemic side effects that we worry about. Lots of medication interactions, not tolerating it well for patients. So that's what that means.
Thank you. Your question regarding foods. Are there any specific foods that tend to contribute to constipation?
Fatty, greasy foods are typically known to slow things down, just in general, even in our stomach and stuff. And then that further promotes, right, decreased motility. That's coming to my head.
Yeah, like, I would probably say like carbs, bread, pasta, those things can kind of bulk and slow things down. Again, not every body is going to react to it that way. Some patients would have sore stool. Some patients, same with like fatty or greasier stool, they may feel like it goes right through them. I think everyone is a little bit different on that. And that's sometimes where nutrition comes in too. And that's where they work with our patients to really personalize care for them and their diet and their body.
Thank you. And are there any websites that you recommend one can visit to learn more about constipation or anything covered in today's presentation?
Good question. I think how patient friendly like the Rome website is. there's pictures and things, but it's more like provider specific.
Yeah. Huh.
That's a good
That's actually
question.
a really good question. Something, yeah. I know, we have, when our patients see us, we have a resource for diaphragmatic breathing, right? For videos to help with that. That's the one, that's that specific type of breathing to help with, helping with our intra-abdominal pressure and helping with contracting our abdominal muscles to help relax our body. It's actually, there's been studies shows that it helps activate our parasympathetic nervous system. And so that's why it can really help with not just constipation, but just overall GI symptoms.
Relaxation, yeah.
Mhm.
Thank you.
That's definitely, that's a really good question. Something I should look
We can
into.
look into, yeah.
Are you asking particularly for constipation, like a
Yes.
resource to look up? Yeah.
Yes. I mean, feel free to send any resources after today's presentation. That way, if anyone contacts the Blum Center, we can share that with them.
Yeah, sure.
We have a question regarding laxatives. How do laxatives work? Do they add water?
In part, they do, yeah, and then they'll stimulate the intestinal mucosa muscles to contract. So there is part bringing in water, but there's part stimulation to the bowels as well.
Thank you. All right, so while we wait to see if there are any additional questions, we have a question regarding what was the website? I believe you had mentioned, is it the diaphragmatic breathing?
Yeah, we could send that over to the Blum Center.
Okay, thank you. I'll enter the Blum Center website in the chat. That way, if anyone would like to reach out to us regarding resources shared, feel free to email us. And we are at pflc@partners.org. All right, so while we see if there are any additional questions, are there any final thoughts you'd like to share with the audience today?
So keep up with your hydration and your exercise, and it's all helpful for the gut.
Thank you so much. And for everyone joining today, thank you so much for joining us. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. It will be made available on the Blum Center website at massgeneral.org/Blum-Center. I also included that link in the chat for you all. All right, everyone. Thank you so much.
Thank you.
Take care.